Hey everybody, how you guys doing today? This is Jim Prusak, physical therapist from the Pain PT, and today we got evidence of the week. I'm going to share with all of you today, and I love to bring you guys evidence. You guys know that as a health practitioner, licensed health practitioner, physical therapist, and having done some prior research, I really value the research findings because they support what we're doing and they start to convince people with evidence what's going on because a lot of people don't believe this. They're thinking every symptom is based on something physical, and we have to break that down, that belief down, that understanding. That's one of your first steps to get you to start to buy into this and start to apply some of the things we're learning here. So let's get to today's paper. And this is a hot off the press study actually done in June of this year. June came out June 24th, 2025. And the title of the paper is Hypervigilance to Pain May Predict a Transition from Subacute to Chronic Back Pain. All right. And we're going to talk about back pain because back pain is one of a large number of people have back pain. Okay. And you look at the prevalence rates of back pain as chronic back pain, it's really quite high. It's the leading cause of disability worldwide. And again, I want to note that if you say, up, I don't have back pain, I'm turning off the video, hang on here, everybody. Stick around because remember, back pain is just one diagnosis. You can substitute whatever your symptom is into that because in this world, it's all the same. Okay, once we realize that it's not a structural physical problem, whether you have IBS or chronic fatigue, chronic back pain or migraines, interstitial cystitis, all these labels, right? Burning mouth syndrome, bladder issues, you got knee pain, you got foot pain, you got, dizziness, vertigo all these things, once we can rule out the physical structural side, the same mechanisms are at work here. Okay, so please stay here. Don't go away. So, tuning out. Jim's only talking about back pain today. That doesn't apply to me. Don't think that way. Okay, when we talk about neuroplastic symptoms, there's such a wide variety of symptoms. Okay, any symptom could be neuroplastic, but back pain is a real predominant one. Again, it is the leading cause of disability worldwide. Incredibly, cases projected to rise from 619 million to 843 million by 2050. I mean, that is a heck of a lot of people. And the prevalence rates here are the people who transition from acute to chronic pain is about 26 to 32%. And we can see that same variable about 20 to 30% of people, no matter what the condition is, transition from acute to chronic. That could be a viral, that could be a COVID, that could be anything really. Okay. And the reason why people transition from acute to chronic, again, comes back to the mind, comes back to these psychological variables. That's why a certain percentage do that, but the majority of people recover. Okay. But when we don't recover, we got to look at the brain now and see what's going on up in the brain. Okay. And they talk here about this biopsychosocial model, right? This is a model that's been talked about and studied for years, where the role of psychological and social factors um, alongside the biological ones are important in this sort of development of and persistence of chronic pain. We see this in the brain, like they mentioned here, neuroimaging studies. I shared some studies about that already. Changes in the brain areas that are involved in emotional processing and cognitive control. So we talk a lot about emotions here. That's absolutely one of the main areas that's involved in production of and persistence of chronic pain. They mention here negative emotions like anxiety, depression, stress. Remember, another word for emotion is stress. So high levels of stress, anxiety, depression are the earliest and most widely studied predictors of the chronicity and low back pain. So we've got a lot of data on that. Other studies that they've done since then have found cognitive factors, including pain catastrophizing, right? That's the mental version of worry, which means fear. Attention, which we're going to talk about today, how we attend, how much attention gets garnered to the symptom. That's called hypervigilance. Self-efficacy is your belief that in yourself that you're going to get better, that you can improve, that you can have some control over the situation. And then beliefs and expectations All these things are associated with the outcome of low back pain. And that's why in the program that I teach in my group or individually, because there's so many factors, I boil it down to that beat. How we're going to beat your symptoms. BEAT. I've done another video on that you can check out. And it's a nice way just to consolidate in a nice acronym how we're going to beat it, how we're going to overcome it. B stands for your behaviors. E stands for your emotions. A is your attention, which we're highlighting today, and T is your thinking. Okay, so we got to change those four areas. And if we can do that, we're going to cover a large percentage of what we know from the research that we can do with the brain, okay, to change this. And just like I mentioned before, these emotions early on are some of the strongest predictors. That's the emotional category. They mention cognitive factors, that's your thoughts, like catastrophizing. They say attention, self-efficacy, and beliefs and expectations. That's also in your thinking category. All right. All that's associated with chronic low back pain. Okay. So what we're going to look at here today, and they looked at in this study, is they took 75 people, okay, who had subacute pain. So this is interesting. It wasn't people who had chronic pain yet. These people were at a subacute stage of back pain, meaning they were 7 to 12 weeks on post onset of the back pain. So it was still early on. And they wanted to see what were the factors that predicted or contributed to the chronicity of pain at 6 months later. So the people at 6 months later, the people who still had pain, what were some of the variables that they could see at the beginning, okay, at the post subacute stage, at the 7 to 12 week stage, and then at the 6 month stage. Okay, it's called a longitudinal study, and it investigates a transition from subacute to chronic back pain. And we're going to look at see what were the psychological and social risk factors here. And they really screen for a lot. Some of the things I want to share with you, what they screen for through different measures, screening tools. They used a couple things, or more than a couple things. They used the Orebro Musculoskeletal Pain Questionnaire. This is called the OMPQ, and this is sort of a broad measure of psychological risk factors. Been well studied. It looks like things on your functional levels, your pain, your psychological factors, fear avoidance, and other things. It covers anxiety, depression, your ability to cope with the pain, perceived chance of the pain becoming persistent, and it also includes fear avoidance. Okay, which we know I've talked a lot about that. Again, it's demonstrated in other studies, moderate to good predictive value in chronic pain, chronic back pain. They looked at another one called the MPI, Multidimensional Pain Inventory. This was the study that's the pain severity and pain-related interference, okay, in relation to psychological predictors that had three sections in it. Pain severity, pain-related interference, emotional distress, social support, life control, okay? They did what's called the HADS, HADS. It's an anxiety depression scale, so measured anxiety and depression. That's again shown good reliability and validity in the previous studies. Perceived stress scale, how the level of stress the person's under. Pain behavior checklist. Okay, I looked at 11 pain-related behaviors such as limping, grimacing, moaning, rigid posture, frequent changes in posture, verbal pain complaints, touching of the painful areas, slowed movements, refusal to perform activities due to pain, crying, and inactivity. Look at all the stuff they measured here, everybody. It's not even done yet. They looked at the pain vigilance and awareness questionnaire. Now, this is related to hypervigilance, the pain vigilance. This assesses attentional bias. Now, remember, attention, this is what we're talking about today. It assesses the attentional bias to pain. So you're focused on the pain in a questionnaire format, okay? And again, that's been studied previously to have good reliability and validity. A couple more things they measured. The fear of pain questionnaire evaluates the fear of the pain, all right? And then finally, the pain-related self-statement scale, which was to assess catastrophizing. That's that mental worry, fear-based thinking, and active coping. Okay, so they measured all these things at the initial measure of 7 to 12 weeks, and then again at a 6 month follow-up. And they wanted to see again what was the contributing factors to the people who developed the chronic back pain. Okay, so there's the setup. Now let's go down to the results here in the discussion and see. So they found again their findings extend the results of previous studies, okay, showing that additional factors such as emotional distress. So here's your emotional category. This is stress, emotional stress, hypervigilance, right, which we're going to highlight today. That's the focused attention on the pain, and pain-related behaviors are associated with the development of chronic pain. So there's three of the beat categories I mentioned that I work with on people. Emotions, they mentioned emotional distress, hypervigilance is attention, and then pain-related behaviors, so your behaviors. Okay, all those three are associated with the development of chronic back pain they found here. As they looked more closely at the data, what they found here was that they found two distinct patterns of psychological and social risk factors that they found. The first pattern was negative emotions, cognition, so there's your thinking, and behaviors. Okay, so those are three of the beat as well: emotions, cognitions is thinking, and then behaviors. The second pattern they found was a more of a positive pattern that helped people was adaptive resilience. So this is the ability to feel like you can be resilient and cope, social support, positive coping, and engagement in activities. Okay, that was another thing they found to be helpful. What they found with this hypervigilance, though, was that it was interwoven between both of these patterns here. Okay, and they said here that the hypervigilance became a main factor here. Out of all the things we're talking about here, it became a main factor in the production of chronic pain. Okay, chronic back pain. So it says it's a predictor of chronic back pain. And this is really important here. They say here how this works, right? Hypervigilance may be a modifiable factor. I mean, we can change this. This is our attention. Its association with catastrophizing and pain-related behaviors suggests that heightened pain awareness combined with negative cognition, which is negative thinking, and behavioral patterns might lead to activity avoidance. So then we start pulling back in our activities. Ultimately, as the pain persists, it may shift into a dominant maladaptive patterns. Okay, so now we're stuck in this psychological patterns of catastrophizing, pain-related behaviors, avoidance, hypervigilance. Okay, that can intensify the pain severity, interference, disability, and finally lead to pain chronicity. So this is what sets up a person to go from subacute pain, okay, where majority of people recover, 26, 32% of the people who transition to the chronic pain, these are the factors that cause the transition. These are the same factors I try to address in people that I work with, these four beat categories: behaviors, emotions, attention, and your thinking. Okay. So what they saw here was that this hypervigilance, though, like I said, emerged as a predominant risk factor. Okay. Above and beyond the other things here. Okay. And what they say here is that hypervigilance to pain emerged as the strongest predictor at the subacute stage for the chronicity of back pain. And this aligns with evidence linking pain hypervigilance to higher pain severity. So really what I want you guys to take home today is that this is really important. It's an important category. I spent a lot of time on this. Includes things such as redirection of our attention towards safety, okay, learning how to do that and not focus directly on the symptom. And also what I call LAO, or we call somatic tracking or pain reprocessing therapy, where we get into this more open, allowing state of what the symptom's doing. We're not focused on the symptom, we're allowing the symptom. We're in a different state of awareness, attention. Okay, those are the two things we got to learn to do on the attentional front that could be of value in helping to reduce hypervigilance. The takeaway today is you do not want to focus on the symptom directly. You're only going to blow it up. I tell people it's like putting a flashlight on the body part where the symptom is. You're just going to magnify it. And as you see in this study today, it became the biggest factor for the transition from subacute back pain to chronic back pain. It was the strongest predictor. So this is an attentional category that's really important. that we need to shift. Okay, and it says here attention plays a direct role in modulating the sensation levels. Um, what we see here is that they say focused attention amplifies signals in pain perception and distraction reduces it. So distraction is, again, I call it redirection, redirecting your attention away. I'll talk about this another time, but it's basically moving your attention towards safety and away from the symptom because the symptom represents threat or danger. But remember, the symptom is not representing true threat or danger. Okay, we call this a false alarm or an elevated alarm from sensitivity. So if you're putting your attention on it, you're just blowing it up, and it's going to, continue to cause it to persist. So we want to move our attention towards safety. We want to redirect it. We'll call it distraction. It's the same thing. They say here that concentrating on pain tends to amplify the perception of its intensity. Of course it does. It's like you're just putting that spotlight on it. Whereas distracting or redirecting attention can alleviate it. And that's really one of your main strategies. Out of sight, out of mind, I call it. When you put your attention somewhere else, the pain is out of sight. It's out of your mind. You're not activating that neural pathway as much. And a lot of you can understand this and have seen this in times when you've gotten fully distracted, fully engaged, fully redirected into something you especially enjoy, or your attention's really garnered by, your pain levels typically go down or they're non-existent. And that's because the neural pathway isn't being lit up more through your attention. Okay, it's really important to understand. Clinical studies have found that individual responses to attention vary, right? Some people, it depends on your level of fear, essentially. Some people still have, even if they're redirecting their attention, there are some people who will still have increases in pain. Okay. And it says here that differences may stem from individual variations in attention. Some individuals are naturally more vigilant to pain than others. So we have to move our attention away. The take home is we can learn to redirect attention in a couple ways. Again, away from pain and symptoms or into this allow and accept, into the more open awareness, somatic tracking, pain reprocessing therapy way. Okay, that's a shift of your attention, basically. And that's why that can be helpful for some people. Again, we have a lot of data, like they say here. Another meta-analysis showed that in patients with chronic pain, attention bias to pain was a big factor. And the last thing I'll say here, they say in the study, is hypervigilance, which is what we're highlighting today, which is an attentional component of pain, correlates with higher pain intensity, greater emotional distress, and psychological disability, even when controlling for baseline pain intensity and demographic factors, so other factors. All right. Again, it's really important. Okay. And again, their study says here it highlights the potential predictive role of hypervigilance to pain in the transition from subacute to chronic back pain. All right, suggesting that hypervigilance during this period may significantly influence pain progression. So, what's the take home, everybody? One, that this is important. This is an intentional component of pain that we need to shift. Number two, we got to shift it. So, the last thing you want to do is be focusing on your symptom directly. It would just will not help. I've seen it personally and other people. You've got two options here that we'll go over again, or you want to learn these two options more, please reach out to me because these are the two options I teach. It's redirection of attention towards safety. I call this starving the symptom of attention. All right. This is out of sight, out of mind principle. And the second one is a version of, you can call it whatever you want, mindful attention, accept and allow, getting into an allowance awareness type of attention. We call it somatic tracking. We call it pain reprocessing therapy. All of this is essentially the same. Okay. It's the way we attend to the symptom. Where's our attention? What type of attention are we bringing? It's a very important category, as you see here, became the most significant predictor in the transition. So that's pretty important. Fresh study, 2025 of June, getting some good information, everybody. So I hope you can take this in and apply it. The attentional category, very important in your recovery. It's one of the four categories that I address called the beat, how we're going to beat your symptoms, behaviors, also important. We'll talk about that another day. Obviously, emotions, I talk a lot about that. Attention, which we're highlighting today. And finally, thinking. What kind of thought thinking are we having? And beliefs and expectations. Hope this helps you guys to take in the data. Again, if you want help, looking for support, need to understand this more, how to integrate this, please reach out to me at thepainpt.com. You can go to my website and hope you guys have a great day and we'll see you guys next time. Take care now. Bye bye.